Hello, and thank you for joining us tonight for our free webinar, Acupuncture Treatment of Sports Injuries and Pain, the Sacroiliac Joint. My name is Jeff Bloom, Education Marketing Coordinator here at L.A.C OMS. For over 40 years, L.A.C OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. We recommend viewing the webinar in either Chrome, Firefox, or Safari, as you can experience some slowness in other browsers. To the right of the video screen, you'll see 3 tabs: Chat, Questions, and Polls. To chat with our attendees or to communicate any technical difficulties, please use the Chat tab. And for questions, please use the Questions tab to assure that our guest speaker answers them at the end of the lecture. Please note that each webinar is recorded, and immediately following the conclusion of the webinar, you'll receive an email with a link to view the video on demand. We will also share the recording with the slides and any other complimentary material in the following week or 2 on our blog. And you may always visit our blog and use the free webinar tag to find all of our previously recorded events. From sports acupuncture to CD to practice management, you'll find something interesting for every practitioner on the L.A.C OMS blog. Now for our featured speaker. I'm proud to introduce Whitfield Reaves. He's been working in the field of sports medicine since he first began practice in 1981. He earned a Doctor of Oriental Medicine degree in 1983 that included a thesis entitled Acupuncture and the Treatment of Common Running Injuries. Whitfield's experience in sports medicine includes the 1984 Los Angeles Olympic Games, as well as numerous track and field, ski racing, and cycling events nationally over the last 30+ years. He has been in the forefront of the acupuncture sports medicine field, emphasizing the integration of acupuncture with orthopedics and anatomy. Join me in welcoming Whit.
Thank you, Jeffrey. So, good evening to you all. It's 5:30 on the West Coast. It's 8:30 back east. I know my partner and buddy and colleague Chad Bong is on here, and he's in Philadelphia. So hello all the way back there, and those of you who are in the way of the hurricane, my best to you. But a lot of work to do, so let me continue. A couple of nights ago, I got a chance to see Ringo Starr in his all-star band. And one of the songs he sang was, "We All Live in a Yellow Submarine." And so for the next hour and a half, or however long we go here, we're kind of like in a yellow submarine. It's really tight. I can't move more than a few inches. We've got some problems where we don't have a pointer. So when I get into some of the anatomical illustrations, I'm going to have to tell you, I can't point. Even a cursor doesn't work with this platform. So we're in a teeny little space. We all got to get along. And maybe halfway through, I'm going to give some of you all a chance to ask questions. And at the end, we will also have a question and answer. So where we are as a community of acupuncturists is that we do orthopedic, sports medicine, acupuncture. We have lots of different names. And what kind of ties us together is at least an interest in anatomy. At least we want to know what anatomical features are involved in an injury. Or if not anatomical, perhaps some of the movement patterns would be what we focus on. Anatomy trains and different fascial movement therapies, specialize in this. So we have an interest in anatomy. We have an interest in movement. If we're really a sports acupuncturist, we also have an interest in the psyche of the athlete. Maybe an orthopedic acupuncturist would leave that alone. A sports acupuncturist wants to know what makes this man or woman tick and how they're working and how their body, mind, spirit is involved in the whole process here. So, but those are some of the features that tie us together. And there's enough overlap here that we'll all agree that we need language more than just Zhang Fu and Jing Lo to get us through the idea of making a good assessment and a good treatment plan for any sort of sports injury. So tonight we're going to talk about the sacroiliac joint, or the sacroiliac joint. And this is interesting. This is not in my book. Most of you all know I have a book, the Acupuncture Handbook of Sports Injuries and Pain. This is not a chapter in my book, and for various reasons. Chad Bong, who I just mentioned, was a contributing author in this book. So the sacroiliac joint is hugely interesting because it's just avoided. It's ignored in Chinese medicine. I don't think any of you have seen any good translation about back pain due to the sacroiliac joint. So let's start off with the what of all this, the joint. So we have a pelvis, and underneath all of that ligamentous structure, we've got a sacrum, and the sacrum attaches to the ilium, and hence the sacroiliac joint. Again, I wish I could point, I can't. You can see the four liao, the four posterior sacral foramen, as the ligaments kind of wrap around on both the right and left side of the sacrum. So the sacroiliac joint is a synovial joint, which means that it has certain properties of a synovial joint. It has a joint capsule. It also has some sort of a disc or articular surface that sits in the joint that aids in its hinging, because most sources, or some sources, call the sacroiliac joint a hinge joint. It's a little peculiar because it doesn't move particularly with any volition. We can't move the joint like we do the elbow by flexing or extending with muscles. So what makes this synovial joint interesting is that we don't have muscles to deal with. We don't have a muscle belly or a tendon or a muscle tendon junction like we have in so many other injuries, and hence trigger points and motor points are out the door. So this is a great example of how we have to think as acupuncturists beyond this motor point, trigger point kind of idea that I think dry needling and the physios that do dry needling have just taken this point of view that everything is about muscles. All pain comes from muscles, and it's not true. And it really limits them, and it limits us to think that way. So in this case, we have a synovial joint that generates pain, and the pain is very distinct in that it is in the sacrum, in the joint by the PSIS. So if you look at the posterior superior iliac spine on the right side here, you'll see the starting point of palpation to get into the sacroiliac joint. Let's go over here, and you can see the posterior superior iliac spine, and you can see the ligaments covering the joint. As we continue, here you have the best shot here. You see the four liao, or the four posterior sacral foramen. You see the posterior superior iliac spine, and into there is the sacroiliac joint. If we go back to the beginning, then have to, as we discussed the what, a synovial joint with inflammation, irritation, laxity, what have you. There's also, outside of the synovial joint, ligamentous structures. In this first illustration, we clearly see the posterior sacroiliac ligaments, this whole strapping system that holds this joint together. Because again, it's not held together like the shoulder with the rotator muscles. Ligaments are the name of this structural component of this particular joint. So when we needle in the region of the sacroiliac joint, we are penetrating ligaments, and then we are entering into a synovial joint. So two things to think about. There's no muscles, there's no tendon, and this makes this a completely different act, completely differently. So the who, what, when, why. Women. Women are your most likely subject. The patient comes in postpartum because remember, the sacrum has to open up. The sacroiliac joint loosens during pregnancy and during childbirth due to hormones. And in fact, it loosens even with the menstrual cycle and the flow of hormones without being pregnant, but very much postpartum. Very typical. A woman's pelvis does not recede itself, and that synovial joint has laxity and therefore pain. The pain is characterized by fixed pain that when you palpate down onto the bone, you don't ever really quite find it easily. The patient says, yeah, that's it, but it's deep and it's in there. So when the joint hides the pain, when you're over the sacrum and the ilium trying to find the pain the patient is trying to explain to you, that is key to a one-sided sacroiliac joint pain. Now, one of the keynotes of a synovial joint is that when you palpate the opening or the access zone of a synovial joint, say gallbladder 40 is access into the talar joint and into the synovial joint of the ankle. We all know from sprained ankles, rolled ankles, when we palpate into gallbladder 40, it's painful, it's sensitive. And that always tells us that something is amiss, something is not right in the joint. Pain or osher on palpation of the sacroiliac joint tells us that the dysfunction in that community, it's a whole community of beings, of things inside that synovial joint, of fluids and of electrolytes and fascial and ligamentous and capsular ligaments holding all this together. Pain is a problem. To the point where as I simplify my work and the teaching of my work, I no longer teach, for instance, Faber or Jet test to assess the sacroiliac joint. And in fact, all I do is palpate. And if the right-sided pain on a right-sided sacroiliac joint is osher, that is enough to make a diagnosis. And there is a study or two that have compared all the different assessment tools and suggested that digital palpation is more effective than Gillette or any of the other tests used, because there's false positives, there's false negatives. For me, I don't do any of those anymore. I palpate, and I palpate carefully and with precision. Here's where we're going to have to be careful here, because we don't have a pointer. So I'm going to go to this illustration right here, the lower illustration. You're going to see the piriformis muscle, and you're going to see the sacroiliac joint on the right side, right-sided sacroiliac joint on the right side of the sacrum and on the left side of the ilium. And so when we palpate in this zone with 45-degree oblique lateral, so just look at me here. This is 45-degree oblique lateral. If we palpate 45-degree oblique lateral right upon that hinge joint line, snug up against the sacrum on the inside or toward the posterior center line of the ilium. That is the correct and most likely way to palpate the sacroiliac joint and see if we can elicit Usher. 45 degrees oblique lateral. Perpendicular, you miss it. Oblique, you push up against the ilium and you don't get through the ligaments and into the opening of the synovial. So where is this? This is bladder 31 and 32 are those top two posterior sacral foramen. Bladder 27 and 28 are level with S1 and S2. And we're going to go a little bit further lateral to bladder 27 and 28. But let's just say this is the region of bladder 27 and 28. Remember, the sacrum, maybe a centimeter or two along that sacroiliac joint. We've got enough room for 2 points. So it's the region of bladder 27, 28, lateral bladder 27, 28, perhaps Tutsun lateral. And it's posterior and inferior to the PSIS, posterior superior iliac spine, the posterior bump there. We're going to go medial and a little inferior into that depression. In the palpable depression with 45-degree oblique lateral angle and we're going to use Usher to confirm, and the patient can be lateral recumbent or prone depending upon various situations. Let me tell you a story. Some of you all know I lived in Maui for a few years. I had a little break and went out to the islands and had a wonderful time. And I had a woman who was in her 4th year of medical school doing a lot of sitting. She was an athlete. She was very, very fit. And she fell bouldering, climbing rocks. And she had fixed pain at the at the sacral iliac joint on one side. She hurt after 20 minutes of walking. She hurt after 20 minutes of sitting. So right into that joint line, she hurt. Now, when you hear this and when you see it and you feel it, you go, this can be nothing else but trauma to the sacral iliac joint. So now we're getting to one other category that we jumped over. We talked about postpartum woman. Now we're talking about an acute traumatic blow to the pelvis or the back where we have acute trauma, and we might call it a sacral iliacitis or inflammation of the sacral iliac joint due to trauma. You'll see this with hockey players when they get pushed against the sideboard. You'll see this with football players that land on their side. You'll see this with cyclists that fall and land on their greater trochanter, and that pressure against the ilium just compresses and irritates the sacral iliac joint. So we, in this case now, we had an acute sacral iliac joint dysfunction, and I had the patient lie prone, face down. I palpated. I could not find Usher, but I was so sure of myself that needled nonetheless into the joint. The needles did not go into the joint well. It was a little bit painful that evening. She was aggravated. The next morning, she had recovered from the aggravation. She was no better. And so I said, okay, let's give you a day to rest. We'll come back to this the next day. So the next day she came, and that is when I remembered my most important teaching on the subject. It's easy to forget the most important things. In order to diagnose the sacral iliac joint, you need to have Usher upon patient. Now, I didn't get that. And not only did I go ahead and make the diagnosis, but I continued on with the treatment. So I followed my next rule now, which was when it doesn't work one way, change the position. So I got the woman in lateral recumbent. I reached around and hooked my fingers around the PSIS, pulled up into the sacroiliac joint. And she went, ah, that's it. That's it. You know, sure. I put 2 needles up into the joint with E-stim. I'll kind of go over those details in a little bit. The needles were not painful. There was no aggravation. And she actually left that day to drive the famed Road to Hana, which is a 4-hour windy drive through the jungle. And she had no pain the whole trip. She hiked into one of the waterfalls at the sacred pools, 2-3 hour hike, no pain. All of this was immediately after correctly needling her. And the correct needling occurred because I elicited Assure in the correct position, which then allowed me to find the correct angle to get the needle into the synovial joint. So all kinds of important lessons there. So position is important, prone or lateral recumbent. Women postpartum with loose pelvis, loose ligaments, and then also acute traumatic inflammation and pain into the sacroiliac joint. So let's now back up again a little bit and let's look at this and let's remind ourselves that when we needle 45-degree oblique lateral, because of course, if we palpate 45-degree lateral to elicit the pain, that will be the vector that we needle into the joint. 45-degree oblique lateral, the same angle and the same direction. So when you needle into the sacroiliac joint, when you look at this illustration, you'll see that the needles penetrate the ligaments before penetrating in towards the synovial joint and into the joint space itself. And what's really interesting about this is I always just say really simple statements. And one of those is that ligaments love electricity. They love E-stim. They love needles. So when we needle and penetrate through those ligaments and we use E-stim, those ligaments are conductive. They're highly conductive. And the mechanical stimulation as well as the electrical stimulation stimulates chi and blood in the ligaments, and it tightens the ligament. It gives you more structure. Remember, ligaments are all about structure, of holding this joint together or helping to hold this joint together, as well as deeper the needle is into the joint itself. And so we're actually taking 2 anatomical structures in a needle, more superficially the ligaments, deeper the joint itself. So it becomes a little bit more difficult to say, well, which layer really caused the benefit? And that would take some doing. That would take a lot of superficial needling to see if you could get the result, which I could never get the result without deep needling. So I think the joint and the ligaments both contribute to this. So what are we doing? I really like, in most patients, I like a 75 millimeter needle. I like a MAC very much. A 75 millimeter needle by 0.25. Now, the MAC is got a little coating on it. It's got a superior metal shaft of the needle, and it slides in there really nice. Now, LASA OMS has this wonderful needle that we helped develop and test, which is also a 75 millimeter needle. That's 3 inches. And 0.25. I would never go in with a needle of larger diameter than 0.25. I want a needle to slide in there with almost no pain and get as deep as possible. So those are my favorite needles there. Sometimes with a really lean male or female, a very narrow pelvis, 3 inches is a little too long. So sometimes I'll use these really nice blue-handled Sarons. These are 0.20 by 50. These are 2-inch needles. And sometimes you'll use these needles. Again, of course, all our needles are 45-degree oblique lateral into the joint. And then if things really fall apart on me, I'll go down to a 40-millimeter or a 1.5 inch needle. And I really like the DBC Spring 10. I also really like the Sarin red or blue-handled 40-millimeter needles. But 40 millimeters is not quite good enough for what we're trying to accomplish here. In most cases, we'll use those for the distal points. But if everything falls apart and you're hitting bone with each needle and all of that, then you're going to have to figure out a different way. And one of those is you can just throw in the towel. If you hurt the patient a few times, use either a silicone cup. L.A.C. OMS, of course, has these, or a glass fire cup. I use both of those over the sacroiliac joint to move chi and blood in that region. So the cupping is usually occurs after needles haven't really sufficed into the deepest position. So we want to stimulate the tissue, and we realize we can't do. We can't do more. So let me just see what else I got in here. So we see all of this. Okay, so on the bottom of this, you see palpate 45-degree oblique lateral. We needle 40-degree oblique lateral using either a 75-millimeter needle or, in a leaner patient, a 50-millimeter needle. And again, you can see the angles in there. So we're treating both the posterior sacroiliac ligaments, as we've stated, and also getting into the hinge joint of the synovial joint. And you would call this in your notes the region of bladder 27, bladder 28. And this is on the Tai-Yang line. So this is a bladder meridian, probably bladder meridian. And favorite point as a distal point to the sacroiliac joint is bladder 58. So I'll often use bladder 58. I'll usually use a 40-millimeter 1.5 inch needle into bladder 58 or something of that nature. So there's a lot of possibilities for the distal Tai-Yang point. But there's more to come. But I tell you what, let me see if there's any questions. Jeffrey, if there's any questions, why don't you come on, and I'm gonna, while you're getting questions ready, I'm gonna see if I can find how to get my video. So let me see if I can get my video. Jeffrey, do I hear you with questions? I don't hear Jeffrey. Okay, so.
Sorry about that.
What's that?
Sorry about that, Whit. So we do have one question from Caroline.
Caroline, okay.
So Caroline would like to know when you said that Usher is better diagnostically than Gillette's, are you saying that pain at the ilium or glute medius is enough to diagnose an SI injury?
I don't know.
Boy, I don't think I said any of that. Say that again.
So Caroline wanted to know, when you said that Usher is better diagnostically than Gillette's, are you saying that pain at the ilium or glute medius is enough to diagnose an SI injury?
No, absolutely not. That won't diagnose an SI joint injury. The Usher is at the opening of the joint space of the sacroiliac joint. period. No other. That's the assure. And if you want to write me, if you want to email me, I can give you show you the study that suggests that that digital palpation over the sacroiliac joint is superior to any other method of diagnosis. Now, that doesn't mean that study is true. In my experience, I'm very comfortable with digital palpation, but not the gluteus medius, not the gluteus minimus, not the ilium, only right over the sacroiliac joint. And let me show you. So you, Jeffrey, are making noises. Your microphone is making noises, so go away for a while. All right, so let me, I'm going to talk over this, and we'll just see how it goes here. So we, is this working?
So right now the video is up on the screen. Are you trying to play the video?
Yeah, I guess I need to do.
If you go into QuickTime and then hit the play button there.
I think I have to do. No, I don't. Tell me what to do.
Did you already do the enabling screen sharing?
No.
Okay, so this is actually the other video. So go to enable screen sharing if you want to share your video.
It says disable screen sharing, so maybe I did enable screen sharing.
Oh, you did do it.
Okay.
So that's the video. So, is this the right video?
This is the video I want, yeah. But
okay. So then if you go into the program for the video, which is the QuickTime player, and then hit the play button there.
I have no idea what you're saying. So
you have, so right now you're in our program, which is like the webinar. And then on the other page where the video is actually being played, that's where the play button is going to be.
This is not acting like it did before.
Let's try, let's see.
Okay, let me.
I see the button. So that means you're in this. You're on the right screen. Do you see the play button?
I'm
in QuickTime Player.
Play. Yeah, I don't know.
Let's see. I see your cursor. Okay.
Yeah, I don't know what to do. Share media. No, that's not going to get me anywhere. No. Disable screen sharing.
Okay.
Okay.
Now,
so let me start all over again.
Okay.
So enable screen sharing.
Yep.
Application window. SI joint. Share.
Okay. And then you have to get out of our program and then click on the play button there. I see your cursor, so you're in the right direction. There we go. All right.
I don't know what I did, but okay. So here we see the crest ilium. This is on the left side, and there's the left posterior superior iliac spine. Okay, and the line down the middle is the posterior center line, and now you see that right where I'm putting that white marker, right where I'm pointing right now, is on the medial aspect of the PSIS about the region of bladder 27, 28, or level with the first and the second posterior sacral foramen. So you're not going to see this well. I'm kind of perpendical in my palpation there. But now I'm going more oblique in my palpation, and I don't think you could see it so well. There is an oblique 45-degree palpation. There is perpendicular, there is oblique, and that is where you would elicit the pain of the sacroiliac joint and dysfunctional pattern. So 45-degree oblique. Notice I'm using more than one finger because it's a more complex hinge of a joint, and it's not characterized by a single kind of circular target, but more of a long or oval target. So that is hopefully something that can then help a little bit. And then here, let me see if I can make this one work. It doesn't seem to be working. Let's enable screen sharing. Let's go to here. Let's go to here. Oh boy, we all live in a yellow submarine. Okay, it works. Okay, so this is a female body lateral recumbent. There is the iliac crest. There is the lateral aspect. Let me show that. That's the lateral aspect of the right side of the posterior paraspinal muscles. The upper line is the 12th rib. The hand now is on the posterior center line, which is the spinal cord, right? The dew line, okay? And so as we follow the iliac crest all the way around, there is the peanut bump of the PSIS. We mark it. It's about 1 centimeter or 2 in size. And then I'm going to palpate. And so I'm palpating on the medial side of the PSIS. I'm marking that zone so I got a clear target. Right now, my finger looks like it's a relatively perpendicular palpation, but let's just see as we progress here if we can see this better. Now with the needles, I'm using 75 millimeter needle, using 3-inch needles, and I hope you can visualize this, all this well. Okay, so we'll use a little alcohol so it goes, and I am again checking on the point. My right to left, medial to lateral patient is making sure I get on the medial side of the PSIS, okay? I want to make sure I'm on top of the sacrum. I'm not too high up. And there I have a 45-degree oblique lateral. And let me just stop right there. Well, it's still going on. You're not going to be able to see that so well. So there's 45-degree oblique lateral going in towards the sacroiliac joint. That's that 3-inch needle. There's almost no resistance. It's a thin needle, 0.25. There with the tube, you can see that 45-degree oblique lateral. Not the best angle because she's lateral recumbent, but that is a fairly good look at a single needle, 45-degree oblique lateral, 3 inches fully embedded into the sacroiliac joint. So, given all this, here we can see an illustration of injection into the SI joint. And this is a very, very crude illustration. But again, you see the nature of the 45-degree oblique lateral sliding up and under in there. And again, so when treating the sacroiliac joint, I like to get 2 needles into the joint. It's long enough, a big enough zone. Look at this illustration on the bottom. You see the sacroiliac joint between the sacrum and the ilium. You see that's a couple of centimeters. So we've got plenty of room in there to slide 2 needles, and I'll use electric stimulation on those 2 needles. That is my ideal technique, is 2 needles into the joint with E-stim, knowing that there will be zones of increased conductivity somewhere. By luck, maybe fortune and maybe skill, but there will be increased conductivity, and with electric stimulation, we will get a passage of current into the tissues. And remember, this is a synovial joint. There's ligaments more on the surface. All of this is highly conductive, and current will flow into the tissues quite freely and invigorate chi and blood. I am absolutely sure, I'm not absolutely sure, I'm kind of sure that at some point we will have data that suggests that electric current going into a synovial joint changes the viscosity and the and some sort of ionic charges in the synovium of the joint, making it less inflamed, making it more viscous, and making it pathologic. Based upon observing what I observe with needles going into synovial joints with E-stim, I'm sure we will have some sort of study someday that will show that. I like the E-stim 2 machine. LASA OMS sells this. It's really rugged, and if you're going out to races and events and mountain trail runs, you don't want to take that beautiful Pantheon machine that for $1,000, gets on, or a rock falls on it and it's no good. This is like $75. You can sit on it, you can kick it, and it still works. So I like this machine, and I won't take the time really we need to discuss electric stimulation, mostly because I don't think it matters what kind of a current or what kind of wave or frequency. I will tell you this, that 40 years of practice, and I use a continuous sine wave at about 8 to 10 to 12 hertz of millicurrent to pain tolerance. So, 10 hertz sine wave, not a dense disperse, not a discontinuous, not any of the fancy stuff, not the microcurrent, not all the fancy stuff that everybody tells us. For instance, the studies of alternating of a low and a high frequency as it targets opiate receptors. I'm pretty sure the work that I do, the work that many of us do, has nothing to do with opiate receptors. We're working on disinhibiting inhibited muscles. We're activating chi and blood into a tendon in a case of tendinosis. I don't think it has anything to do with opiate receptors. So those studies don't turn my head to make me go, hey, quit. Maybe you better find a different way to do things. So, at any rate, keep it simple. But if you have studies, if you have teachers that give you different instructions on how to use E-stim, just get current into those needles, into the tissue. The current will work almost no matter what it is. I'm sure. I don't see patients come back saying, boy, that one didn't work. And then the next time you do a different frequency, they come back and go, boy, that one sure worked. This is not my experience. And so after 40 years of this, I've simplified it to the settings that I've just discussed. So as we continue, then we had a little bit of discussion here about the gluteus medius. Maybe let me see what I on this here. The gluteus medius is hugely important. And so while we don't have a muscle that's holding the sacroiliac joint together, the gluteus medius, and deep to it, the gluteus minimus, or here again, the gluteus medius, and deep to that, with the gluteus medius cut away, the gluteus minimus, are two of the Shaoyang muscles in the iliac fossa. The most important muscles that we've got for pelvic stability, and there is not one acupuncture point on those muscles. That's a whole nother discussion, but it's hugely important. When you look from the side, you're looking here at the gluteus behind, posterior to the big TFL, tensor fasciolata, that's shown here. is the gluteus medius and the gluteus minimus, and our point is the hip and low back master point, Jian Qua, which means strengthened thigh. Jian Qua is halfway between the greater trochanter and the iliac crest, whereas gallbladder 29 is off the gluteus medius and minimus, anterior to it, halfway from the greater trochanter to the anterior superior iliac spine. So if you just look at the Shaoyang line, this perfect lateral Shaoyang line, Jian Qua is right there, and you would be remiss if you ignored this point. Looking at the Trendelenburg gait or posture, looking on the right side here, you see what happens with a weak gluteus medius on the right side. When you stand, single leg standing, right-sided weak gluteus medius, the left pelvis drops. And look what happens to the sacroiliac joint, as well as the lower lumbar vertebrae and the discs and facet joints of the lower lumbar vertebrae. This is a disaster made to happen. And so the gluteus medius becomes a hugely important piece. If we look at the left side of this, we see a strong gluteus medius and single leg standing. You see the pelvic is stabilized. Considering when we walk, every step we take, we're single leg standing 30% of the time on each side. So 60% of our walk, we're on one leg or the other. And if our gluteus medius is not strong and engaged, then we have this Trendelenburg gait or posture. And even if just there's the slightest pelvic tilt, that will add to irritation and contribute to a sacroiliac joint dysfunction over time, as well as many other things in the lower spine. This is hugely important. We got to remember that there are two kinds of muscles. There are postural muscles and there are phasic muscles. Postural muscles are what we use to keep us up with gravity and keep us from falling into a puddle, a pool of human blah, right? So postural muscles are important. They keep us upright. Phasic muscles are on-demand muscles, and the gluteus medius is a phasic muscle. Phasic muscles tend to inhibit. If anything is going wrong, if they get irritated, if you sit too long, the phasic muscle, the gluteus medius, will inhibit. And hence, so many of the treatments that have been suggested with a motor point or a trigger point or needling into a muscle belly is to activate an inhibited muscle. And if you really look at this, we're usually doing this on phasic muscles that tend to get inhibited, not on postural muscles. Postural muscles get tight and they contract like the quadratus lumborum tightens. It doesn't get weak. It's tightened and contracted as it's trying to hold the posture of the lumbosacral spine together. So the gluteus medius is peculiar because it is very important for posture in the sitting world. But this was designed 1,000 years ago before everybody sat. So it's a huge design flaw. We should get upgrades or, get a version 2 or version 3 of this, but it doesn't seem to work that way. So we can needle the extraordinary point Jian Qua to activate the muscle. And we can, of course, have our patients doing exercises to engage the muscle and neuromuscular movements, planks and bridges and squats and standing on one leg for that matter, So there's many ways to do this. Clams was Jane Fonda's way to do this. There's just a huge amount of ways to remind this muscle to work and keep it activated. But we need to use this with the sacroiliac joint. So Carolyn, who asked, is pain at the gluteus medius or the gluteus minimus in finding in the sacroiliac joint dysfunction? I said no, but with most sacroiliac joint problems, there usually is weakness and pathology in the gluteus medius. And so I really like to use the Jian Qua, as I just suggested. And let me see if I can figure this one out now. I'm going to find another thing here. We all live in a yellow submarine. Ringo was a lot of fun, by the way. And so let's take a look here. So here I'm palpating the tissue here. Here I'm palpating the superior aspect of the crest of the ilium on your left side as we look at it. And on our right side, a finger is on the greater trochanter. So halfway between the greater trochanter and the iliac crest is this extraordinary point, Jian Qua. Remember, halfway from the greater trochanter to the ASIS, the anterior superior iliac spine, is gallbladder 29. That's off. That's in a whole nother world. Forget about it. The X shows us this zone of the extraordinary point, Jian Qua. So I'm going to get to the middle, and then I'm going to roll. Again, I'm using fingers. It's not a single little point like, say, gallbladder 40 is a little circular point that's finite. This is a zone. And I'm rolling off the TFL. Remember the picture back there of the tensor fasciae lata, the red emboldened muscle there. That's running anterior to this and toward the region of the known acupuncture point, gallbladder 29. We're getting posterior to all that. And we are finding the depression on the posterior side of the TFL. I'm not going to say that again. I think that you will have a chance to view these again and again. If you need to hear this a few times, you need to hear it a lot of times. To me, this is some of the most important information that I have from 40 years of practice. There's almost nothing more important than what I'm talking about right now. You can practice based solely upon treating this muscle in a sitting population. Now, if you lived in Iowa with corn farmers and ranchers, not so much. But you live in San Jose to a sitting, high-tech, screen-oriented clientele, this is a big deal. So I'm rolling off, and the hand now, that is the gluteus medius. Now I'm rolling off the hard TFL and going into the depression. You can see that depression. You can see my fingers float into that depression. Let me see if I can stop it right there. It's really pronounced. It's very obvious. And the patient will always or almost always go, that's it. Sure. That's the point. Regardless of whether they complain of any hip pain or gluteal pain or not. This will be sure in many of these back pain. Sacroiliac pain is specifically what we're speaking about right now. So once you locate the point, you confirm it, and you get a needle, and you needle into that zone. Now, here is a perpendicular needle, and again, the needle is a 75 millimeter needle. Now, I cut out the needle illustration I had on this just because I needed to save some time. A 75 millimeter needle will penetrate through the gluteus medius and through the gluteus minimus, and it will come to an end by hitting the bone of the iliac fossa. But a nice, simple, perpendicular needle will pass through that zone of the extraordinary point, Jian Qua. So if we go back our PowerPoint, we'll see here the gluteus medius is cut away and the gluteus minimus, but halfway between the iliac crest and the greater trochanter, you can see how the needle would penetrate the gluteus minimus in a deeper position. And I think I want to just get a little further this way. There's the gluteus medius that we will penetrate through. We will reach the gluteus minimus before penetrating all the way to the bony iliac fossa. But look at that depression halfway between the greater trochanter and the iliac crest. You've got this depression that you roll your fingers in, you put a needle in there, and the gluteus medius, as a phasic muscle that gets inhibited, gets turned off for prolonged sitting, is a disaster for back pain, leg pain, hip pain, pelvic pain, and it is so easy to fix this with needles into the muscle belly. Some of these may be a motor point or a trigger point or just the muscle belly. To me, it's all the same. There's multiple motor points here, so I'm not looking for a motor point per se to activate this muscle. So again, there's the minimus deeper to the medius. There's that tensor fasciae lata that we roll over to get to the posterior side. There's Jian Qua, right exactly on that Shaoyang line. And again, to remind you that by activating this muscle, we get to stabilize the pelvis in the treatment of sacroiliac joint pain. So basically, we have local point, the region of bladder 27 and 28 going right into the synovial joint, penetrating the posterior sacroiliac ligaments to get into the joint space. And then we have a adjacent point that helps stabilize the pelvis to assist in the treatment by activating the gluteus medius and perhaps even to some degree the gluteus minimus. Again, we're penetrating through those ligaments for the local treatment. And here on the right side of the bony ilium, you see the iliac fossa, and you see that when you penetrate coming in from the side on Jian Qua, you're going to hit that bone eventually, and that's really not a problem. And let me just finish off by saying that the quadratus lumborum would be our third piece. And this is what, in my teaching, I call the triad. The triad is the gluteus medius, which we've just covered. But by that, I mean the gluteus medius and minimus, the sacroiliac joint, which we've covered in more depth here, and then superior to that, the quadratus lumborum, which is the Shaoyang type of lumbar musculature that's deep to the paraspinal muscle. And so we have the paraspinal muscles this way, and we've got underneath that, maybe that would be the way, we've got the quadratus lumborum reaching out to the iliac crest at the top. So the Janet Travell, who I studied with in 1983 and 84, was very clear that the quadratus lumborum and the gluteus medius work together in stabilizing the pelvis and the lumbar spine. And my work now is when I have back pain, when I treat back pain, I use the triad. I use the gluteus medius, quadratus lumborum, and the SI joint. I'm using the large structures. It's almost like any of you have been around Pilates people. The Pilates people say, let's start by activating, let's get the big muscles working here first. Eventually, we'll get into those little muscles and see what's wrong. But Pilates will often take a big muscle approach. This is a big muscle approach. The patient may have bladder or dude channel or bladder channel pain, low back pain. And here we are all the way out to the side with the gluteus medius and the quadratus lumborum. We're treating the more lateral aspect of these muscles that are supporting the lumbar spine and the pelvis. And it's just a wonderful kind of contrarian way to look at treating back pain. That's another story. Right now, we're talking about the sacroiliac joint, and we're done talking about the sacroiliac joint. So I'm gonna stop here for now and see if anybody has anything else they want to ask. And while Jeffrey, if you want to gather some questions, I just want to add to you that just things, I'm not trying to sell anything here. I've donated my time for free on this, but I do have a book, the Acupuncture Handbook of Sports Injuries and Pain. We have a number of webinars available through L.AC OMS, and they've newly been able to gotten access to these webinars. They're old, they're 8-10 years old, but they're very precise. They don't cover everything. They don't cover the sacroiliac joint, if I remember correctly, but we have webinars on a lot of very common injuries, about 1 hour in length. I think very reasonably priced, very, very good location and pretty good camera angles, considering we did not have high definition video at that point. I'm in the process right now of making a whole new webinar program with everything updated. I see somebody here saying, I love those webinars. And I'm not trying to sell this, but I love them too, because they're just so to the point. They don't waste much time, getting to the point. I do teach what I call the Acupuncture Sports Medicine Apprenticeship Program, and I have for 10, 15 years. And that has been a big piece of my work. And I've decided very recently that we are going to bring that to an end, and we're going to be teaching the apprenticeship program the way it has been. Somebody's, how did I do this? Sorry about that. We are going to be not teaching this apprenticeship program too much longer, but we are morphing into other ways to be able to continue to teach this medicine, which we love. And at this point, we is a group of colleagues who all are part of assisting me in teaching, and who take certain segments of the teaching themselves now. And so we've grown up a lot. And over the, since 1986, when I taught the first, what we think is the first acupuncture sports medicine, sports acupuncture course, we've really all learned a lot. And there's so many of us all helping to contribute to this community from different sources and different angles and perspectives. And I think the acupuncture community in this arena, I think we are probably the best on planet Earth for orthopedic and physical medicine. I think that we are better than what is happening in China. I don't think we will ever be able to touch them in terms of herbal medicine and the volumes of patients they're able to do, but they haven't quite gotten to this anatomical perspective to the degree that we have. And I'm very proud of all my colleagues and everybody that has contributed over the years to the growth of this. So I think we're all doing great, and you all are all part of it. And every time you treat an anatomical point, you're just adding to the collective understanding of this whole thing. And I will shut up. Please, Jeffrey, question.
Well, there was a bunch of questions around the E-stim. I know you answered it. Just in case anybody missed when you said it, can you talk about the average frequencies that you use and then the duration?
So I have come to the conclusion that there is absolutely not a definitive way that E-stim has to be done. I'm very precise in my work. And with electric current, I have had nothing to indicate that there's a right way. I tend to use a continuous sine wave, so I'm not doing a dense disperse or a discontinuous wave, a setting that has two different things in it, right? High frequency, low frequency, high frequency, low frequency. It's just a continuous sine wave, about 8 to 10 hertz. I use millicurrent, not microcurrent, and I just turn it up just so the patient feels tapping. Very, very simple. I like it very much, and that works fine with me, although I cannot say that any other way is wrong or lesser than what I'm suggesting. If you don't have a teacher that tells you definitively do it this way, then I would suggest you just listen to what I have to say and try it, and make your variables be the needles and how you put your energy into the perfect needling, and so you don't have to worry about the E-stim part. But one thing interesting, I play music. I play right now in a really wonderful band that I'm new to, and right now my brain's exploding because I had to learn 35 new songs. I play electric bass, but somebody sent me this video of this controversy that came up over how a lot of the old cellos and violins were not tuned to 440 cycles per second. For 440, they were down to I think that was for middle C, or middle C above A above middle C, and it was in the 430s. But everybody now follows this 440 frequency, and so there's this guy wrote this long eloquent article about the mystical properties of this 430, 432, or 433 instead of 440, and explained that it was all repetitions of 8 cycles per second. And the mathematics all boiled down to this 8 cycle per second and how they all work together. And that 8 cycles per second was what was coming off of the earth in the vibrations coming off the earth. And I went, wow, well, 8 cycles per second. That's kind of what I try to do when I do E-stim. When all is said and done, that's what seems to feel right. It was interesting. It was fun. Is that science and is that right? I don't know, but it is a good story. Continue, Jeffrey. I digress.
I mean, it happens. Warren would like to know what level of pressure is required to elicit a positive response. Should the patient be very reactive, or is a mild, dull, achy sufficient to be positive? And can you speak to a positive sign to treat?
I missed the last part. The pressure is obviously going to vary from patient to patient, but the achy, dull ache it doesn't have to be. It's not a sharp, fixed pain. It's going to be more of an achy, dull feeling, and just compare sides. Go to the other side. If it's exactly the same on the other side, then it maybe is not a positive sure for the sacroiliac joint. It should definitely be more sensitive than the other side. But you want firm, continuous pressure, but you don't want to overdo it. You don't need to really, lunge into the patient here. There was one last thing you said that I'm not sure I got.
Basically, he wanted to know if you could speak to a positive sign to treat.
A positive sign to treat. I'm not sure what that means. Can you translate that and use different words?
Let's see. So I think basically, that was just clarifying, what he was asking is like, is the mild, dull, achy sufficient to be positive? And if that's not, what would be the positive sign to treat?
So So you would always, we have syndromes, as you know, you've probably studied them until your ears fell off, but so yeah, palpation is a sign. And the symptoms are one-sided back pain, deep, fixed into there, hard to locate, deep fixed. Sometimes there's a clunking if the joint is not stabilized. Some women, you'll actually have a little bit of a clunking of the joint being unstable. So pain plus pain on Usher, it would give you plenty of reason to think that the sacroiliac joint was at least part of the low back pain that the patient was presenting with. It might not be everything, but some. What else do you got?
Let's see. Damien would like to know, has the book The Body Electric informed any of your work?
No, Body Electric has not informed any of my work.
Okay.
Should it?
Damien might think so.
I'm writing it down. It's been around forever. I'll take a look at it. I've seen forever.
We'll find out. We'll find out in the future. Okay. Markham would like to know, how about using the sound that is associated with the meridian?
I know nothing about the sound associated with the meridian. That could be very interesting. I know nothing about it. I don't know what the sound is. I don't know how to reproduce the sound. It sounds interesting, but I'm an acupuncturist, and I don't go off to anything other than acupuncture. That's all I do. I figure I can do one thing well, and I can needle well. So I don't try to do microcurrent and laser and sound pitchforks and this and that. I just try to needle. That's all that I do. So I'm sure there are great ways to stimulate movement of chi and blood and create harmony. I only know the needle. That's the only thing I know. I don't know much else.
Looks like James wants to know, which I'm not sure if we have the context for, but he said, where are you inserting the second needle for the current?
Very good question. I will try to put 2 needles into the joint. Those needles are about 1 centimeter apart, because as we've said, that joint line is maybe 2 centimeters long. So I should be able to get 2 needles oblique lateral into that zone, maybe about 1 centimeter apart. If for some reason all I can do is get 1 needle in there, let me do this. If I can only get 1 needle in there, there's no more room, I will often put a second needle in bladder 53. Bladder 53 is below the SI joint, sitting right on top of the piriformis. Now, technically, bladder 53 is superior to the piriformis. Bladder 50, level with S2. Bladder 54 is inferior to the piriformis, level with S4. Bladder 53 is an adjacent point to the sacroiliac joint. And so if I need a second needle, I'll put the second needle into bladder 53 and use E-stem between there. And while we're on this subject, the sacroiliac joint I didn't really mention this, is the first place that I go look when there is a piriformis syndrome. I don't treat the piriformis. I don't even believe that the piriformis syndrome it barely exists in and of its own stature. It is the result of instability, and I try to stabilize the sacroiliac joint. And you can look at this picture here and kind of go, gosh, if that joint is moving and clunking around and not stable, the piriformis is going to tighten up and try to hold it together. But I mean, that little wimpy muscle is not really designed to stabilize that joint. So you get a very tight piriformis in response to instability of the sacroiliac joint. And if the gluteus medius, as we've already shown in prior slides, the gluteus medius is also not, if it's inhibited, if it's not turned on, then we also have problems. So those are the two things that I look for with the piriformis: the SI joint and the gluteus medius. Rarely will I ever needle into the piriformis. My whole book, I barely ever talked about the piriformis. When I teach 3 days in my apprenticeship program on back pain, I think often we don't ever even treat the piriformis. So we view that, I view that as a secondary occurrence, that once you start needling into the piriformis, oh, you got aggravations. And if you irritate the nerve, to me, it's a big mess. I don't like messes. So I try to stay away. Keep going.
All right. Patty would like to know, what points on the QL do you use? Motor points?
I don't use the language of motor points so much. So the problem with motor points is that it implies, there are multiple motor points. Now, some what are called motor points are where a motor neuron enters the muscle. Some of the motor points are just areas of increased conductivity without necessarily a motor neuron. So, but muscles have multiple motor points. Now, Matt Callison has mapped out his favorite ones to get to. But for instance, on the quadratus lumborum, you have a postural muscle that's tightened. So we don't have a problem with an inhibited weak muscle. We've got a muscle that we have to release. I would tend to want to needle into the muscle belly or the trigger points, like P gun is the region that Janet Travell calls a trigger point. I would want to try to release the muscle and elongate the muscle, not by activating or disinhibiting the muscle, but by releasing the muscle. So I don't think of the quadratus lumborum within the context of motor points. Do we needle a motor point while we're doing it? Very, very likely, because here's a motor point, this triangle right there, our star, that's a motor point. So the upper X, the lower X, P gun, Yao Yan are the trigger points in Janet Travell's work, and then that's one of the motor points in Matt Callison's work. But that whole edge of the muscle is where I needle. So I'm never trying to find a motor point. I'm trying to find a dense pathologic part of the muscle to release the muscle. I don't care. I don't call it a trigger point or a motor point. It's just the muscle belly. So it's a little different language. It's a little different point of view. But if you know motor points, that would help you get more precise for certain things. So there's lots of ways to accomplish this. I hope that makes sense.
I think it does.
Keep going.
Someone would like to know, can you sum up this treatment? Are you needling SI joint, medius minimus, and the QL with electricity at once or in section?
I use, well, this is a wonderful machine, the Easton 2. I mean, I love this dang thing because it only has 2 leads. So you can only have, you can't see any of this, but that's okay. I can see it. You can only have 4 clips. So you can't get carried away with putting all these needles in things. Or putting clips on all these needles. So what I tend to do is try to see can I accomplish this with 4 points getting current. If I can do that, I'll do that for, say, a 30-minute treatment. If there are other points that need it, for instance, we've got 2 needles in the sacroiliac joint, And we've got 2 needles into the gluteus medius at Jian Qua, and we've got several needles in the quadratus lumborum. And we want e-stim in all of those, then I will tend to then break down a 30-minute treatment into 2 15-minute segments. So I'll do these 4 needles for 15 minutes, turn off the e-stim, take this off, put these over here for the next 15 minutes. So I'll do 2 segments, but I don't like to just have so much current going in that the body just gets kind of overwhelmed by electric current. So I only do 2 at a time, but I will do 15 minutes of 2 and 15 minutes of 2 sets of needles if necessary. In this particular case, it could be likely that I would leave these 2 guys into the primary points of the sacroiliac joint, and the other 2 will go into the gluteus medius for 15 minutes and go into the quadratus lumborum the second 15 minutes. So it's sometimes rotating or floating how I do that. And I think some of that is just practitioner sort of style. I don't think that there's a definitive way that you have to do it a certain way. I think there's lots of ways to do that. That's what I do. What else?
All right. We still have more questions, so hopefully you're okay to keep going for a bit.
Sure.
Let's see. Looks like Karash would like to know, have you ever treated somebody with leg length discrepancy due to a shorter leg bone?
Oh, absolutely. All the time. So leg length discrepancy is very, very common. Sometimes it's from the pelvis, and sometimes it's from an anatomical short leg. You need a half body x-ray to really make a good diagnosis, to measure it varies. I don't know what they're doing now. If they're going from ASIS down to to the medial malleolus. I'm not sure, but they want to measure to see if the bony difference is in the big bone or the tib-fib zone, because it does make somewhat more of a difference. So that's something that I always have somebody who can diagnose leg length discrepancy, and I am absolutely okay with putting in lifts on the short side when there's 5 millimeters or greater, when there's a big discrepancy and the patient's got a lot of symptoms. Sometimes the body just gets overcompensate, and I don't think there's any way to deal with it other than lifts. So I'm totally okay with that. What else you got?
All right. Sylvia would like to know, any suggestions for treating this condition with someone who has fusion L4 to S1 with hip replacement?
Yeah, I would refer them to someone else. Yeah, I especially if it was relatively recent. I don't like the case. I would probably send them to somebody who could do this because I wouldn't do it so much. You know, there's just too many things that can go wrong. You can introduce infection into titanium, implant in the body. It can be a disaster. And so, I mean, I would definitely really, really be careful with clean needle technique and use betadine, on the skin. But I don't like it. It's just not a case that I would want to take because I couldn't predict the outcome. And because I have taken that case, then I don't have experience with it. So it's difficult. It's wildly, unpredictable. And I try to limit those kind of patients to a very small part of my practice, because these are the people that are out there saying, boy, I saw whatever, I can't remember your name. I saw Mary out there and And boy, she sure is nice. And she's really, really, really trying to help me. Well, how are you doing? I said, well, if anything, I'm worse, And so you've got these people that talk about how wonderful you are and how caring you are, but they're not really getting her. And that is the advertisement that is the communication into the community about your clinical effectiveness. So it's a little bit of a hard-nosed point of view to deny service to somebody. But if you really don't know you can help them, it might be more compassionate to not help, to not attempt to, than to have any false hope about maybe being able to help them. I'd be very careful about cases like that. I would be very, I very much want to limit those. And I'm usually suspicious of practitioners who have too many of those kind of patients. So keep going.
All right, next one. Patty would like to know, do you only treat them on their side? What about bilateral pain?
I treat, for the SI joint, I said that you could do lateral recumbent or prone face down. If you remember that first video that I clumped around trying to show, that was the patient lying face down. So you can palpate, you can treat face down or lateral recumbent, either way. If it's bilateral, then of course you can face down and get access to both sides. So if you have a situation where, for instance, the SI joint palpates absolutely definitively asher with a very clear depression, 45-degree oblique lateral, when they're lying on their side, and you want to do a bilateral treatment, you might just have to say, okay, I got 45 minutes. I'm going to put you 20 minutes on the right side, and then I'm going to roll you over, and I'm going to do the other side. Sometimes you just, you have to, it's better to have very good, perfect treatment for a shorter amount of time on both sides rather than put them in a position where the access into that tissue is not ideal. You want perfect needles. And position is part of getting a perfect. So paying attention to position is really important. So sometimes I'll have 15 minutes in 3 different positions to get 3 different things that all are contributing to a condition. And it takes time, and it's, it's difficult, but keep going.
All right. So this one I tried to look up online while we were talking. Do you know if the online CEUs through Net of Knowledge, if those will count for CEUs in Texas?
I don't know. We have national, we have California, and we have Florida. You'd look. I can't remember if they did Texas application or not.
All right. Well, Patty, can you send an email to our customer service team, info@lasaoms.com, and we will make sure to get that answer for you. Let's go to the next question. Terry would like to know, do you have any recommendations for use of an SI joint belt?
Yeah, an SI joint belt can be really useful. I've never seen anybody but a woman wear one. A postpartum woman, and sometimes the ligaments are so lax that it feels so much better to hold it together. And so while you're, it might take you a couple of weeks of needling. Look at the illustration here. Needling through those ligaments to tighten up the ligaments. And remember, it's a synovial joint, and that joint tightens up, and stability occurs both with the joint, articular tissues of the joint, as well as outside the joint, these posterior sacroiliac ligaments. But it happens pretty quickly. And patients immediately kind of sense the stability. So I think 2 or 3 weeks, and the patient may be able to kind of go, yeah, no, I feel strong enough here to to be able to do this without a belt. Remember, you can't build your muscles, hold this together. So this is ligamentous. I mean, the musculature, of course, helps. I think a belt is a very reasonable temporary piece while you're treating the patient.
Do you know any brands or anything that you'd recommend for those belts?
I don't. I don't. But boy, I went online kind of recently to order one, and I realized that I wasn't current on the subject. But they all kind of are the same with Velcro, and yeah, I don't think you can get a wrong one. You know, look at the reviews and all that. It's fairly simple of holding things together. I don't think I don't think it's the physics of this are not complicated. It just holds it together. So I think you're okay. I don't think you'll make a mistake if you just do a little research. Yeah.
All right. Next question. Itzel would like to know, no e-stim if there are metals in the joint, right? And is there any chance to treat this with laser or LED?
Yeah, right means I know, and I can't say that I know. So I avoid e-stim around, metal, but right, is that a fact? I don't know if that's a fact. So I think you should ask it's from other people as well. I stay away from it, but I can't say that it's definitively essential that you stay away from e-stim around metal. Second part of it was, what was that? Second part?
Second part was, do you think that you can treat it with a laser or LED?
Oh, yeah. Yeah. So I have no experience. As I said, I am an acupuncturist and I focus on the needle. I really don't know. I've tried all kinds of laser machines. I've never been able to get anything that worked even remotely close to what a needle does. So I don't have the skill with those other modalities. But somebody who only does that might be able to give good advice on that, as an alternative for e-stim, in a case with titanium or other metal, in the body. So, yeah. But again, man, try not to have too many of these patients because they're tough, and you got to learn. You learn by treating normal cases and observing, clinical results. And these are wildly unpredictable. So be careful.
All right. Next question. Scott would like to know, do you needle the triad as well as a distal point?
I needle the triad all the time in the treatment of back pain and all. Distal points, absolutely. I'm adding to it. It's Xiaoyang, so I'll often use gallbladder 34. I'll often use gallbladder 41. Sometimes I'll cross gallbladder 41 with Sanjiao 5 as a Dumai type of treatment, but again, that's Xiaoyang. It's also Taiyang, the back and the SI joint is Taiyang, the bladder. So sometimes I'll use bladder 58, as I said, bladder 60. Bladder 65 is the shoestring point, just like gallbladder 41 is the shoestring point. So I will pick apart and try to find some way to use both Xiaoyang gallbladder and Taiyang bladder distal points that work with this particular treatment. Yeah.
And then Mary wants to know, are you able to treat scoliosis?
Am I able to treat scoliosis? Yeah, I can treat scoliosis. Can I help it? No, So I refer out scoliosis, but there's one thing that, there are people who specialize in scoliosis. They're now doing side planks that that may be turning the whole corner on scoliosis and some new techniques, side planks. So you got to find somebody who really is doing this. The most important thing with scoliosis is don't start chasing up the spine. You know, what I do is I find the base of the quadratus lumborum and the gluteus medius on the affected side that's carrying most of the weight. And I treat all scoliosis there down at the pelvis, and I never chase up the spine and, you know, try to satisfy my own mind by doing Wato Jaji or bladder channel points all up and down the spine. Never done anything ever for me in the treatment of scoliosis. But the best relief that I've seen has been with the quadratus lumborum and the gluteus medius. One-sided, definitely not bilateral, one-sided, based on palpation, but you'll also base it upon just observation of how that patient pelvis is positioned to carry the weight of this curved spine. So I'm not saying don't treat it. If you could get good results with the quadratus lumborum, gluteus medius, and maybe even the SI joint, maybe all three of those structures are really involved, you know, in an old patient with scoliosis, and then you could help them and then have them go to a specialist that's working with movement and exercise and working with those muscles to try to at least keep the scoliosis from progressing. So, at any rate, one more, and then we gotta let you go. And
I think it's you. We've kept you going for almost 2 hours.
Yeah, it's only 7 o'clock here. The hurricane's gonna hit you before we're done here, man. So what else you got?
All right, let's see. Let's go with Susan. How much treatment do you think is needed to stabilize a very lax, stretched thigh joint, and how often and for how long?
I would say 2 treatments a week for 3 weeks and then reevaluate. But that's what I would say for almost anything. Twice a week for 3 weeks and reevaluate. The patient should definitely feel better after 3 weeks. Absolutely feel better if you're doing this right.
All right. Well, we can't thank you enough. So this is Whit's second webinar with us. The first one was back in April of 2018. So, you know, it's really nice to have you back with us again, and we hope that you would be willing to do this again in the future.
Certainly.
For everyone who still has questions from Whit, you can check out the 2019 Acupuncture Sports Medicine Apprenticeship Program. You will all receive links to this program through your email about 5 minutes after we end. We also do have another webinar coming up next week, which is going to be featuring Dr. Pony Chang. So please check your inbox next week for a registration link. And Whit has his website up on the page right now, which is whitfieldreaves.com. Thank you all for joining us. Whit, thank you for giving us almost 2 hours of your day, giving such great information. Everyone enjoyed, as did we.
Good. I disrupted your talking. I could get both my website and my email. If you really had a question, email me. I can try. I'm not always great with questions, but I do my best. So, at any rate, thank you guys all. It's late for most of you back east, and cool. Thanks for hanging around, and keep it all going.
All right. Well, thanks, Whit. We'll talk to you soon.
Okay, we're going to get out of the yellow submarine and get back out into in the world. See you later.
All right, take care.